So Pevonedistat is a protein metallation inhibitor. There were multiple studies in both MDS and AML suggesting that it might improve response rates and outcomes either when combined with azacitidine in AML or in MDS. And so we did a study of a triplet therapy of azacitidine, venetoclax, and pevonedistat in patients with newly diagnosed secondary AML, and this was based on some other data suggesting that it might be particularly effective in secondary AML. And we also evaluated it in patients with MDS or CMML after hypomethylating agent failure. Now, I will say that because of a randomized study, the PANTHER study, which was negative and did not show a benefit of pevonedistat in the frontline setting in MDS and CMML, we subsequently closed that arm. However, we did fully accrue to the AML arm, which is for patients with newly diagnosed secondary AML. Now, this was a very poor risk population where more than half of the patients had previously received a hypomethylating agent for prior MDS or CMML. And this is a patient that historically we know has dismal outcomes with a median survival less than 6 months. That said, with this combination therapy, we still saw relatively high response rates, similar to what we see with in the VIALE-A study of azacitidine venetoclax, despite the poor risk population. However, unfortunately, the duration of these responses was still relatively low. Now, it was enriched with patients who had TP53 mutations or MECOM rearrangements, which we know are the poorest risk subtypes of AML, and so that did account to some extent for the poor outcomes in this cohort. And in fact, if you eliminate the patients with TP53 or MECOM from the analysis, the outcomes actually look quite good, despite many of these patients, all of these patients having secondary AML, and some of them having prior hypomethylating agent exposure. So ultimately, this needs to be confirmed in a larger study. There is a randomized study that has completed accrual in newly diagnosed AML in older patients that randomizes patients to azacitidine plus venetoclax versus the triplet regimen of azacitidine, venetoclax, and pevonedistat. And we expect that paper to be published soon, and we eagerly await the results from that.